about MDROs and long-term care. So it's my distinct pleasure to introduce our grand round speaker for today, Dr. Lony Mody. Lona is an endowed professor of internal medicine at the University of Michigan and physician scientist at the VA and Arbor healthcare system, and a professor of epidemiology at the School of Public Health. She's funded by the NIH, VA, CDC, and AHRQ, as well as foundations. She directs an innovative translational research program on infections and aging. She leads her division's T32 grant, NIH-funded Pepper Center's Pilot Core, and with support from NIA K-24 mentors the next generation of physician scientists. She currently serves as the interim division chief of geriatric and palliative medicine. Nationally, besides her research, she is recognized for her work in immersing principles of aging research in various medical, surgical, and related subspecialties. A couple things that Lona left off is she's a very acclaimed artist, and she's actually published her art in medical journals. Lona is also a wonderful mentor, as John Mills can attest to, as Lona and mentored John together. And Lona's also, she didn't put this on her introduction, but she's a close friend and colleague of mine, and I've valued her collegiate. Everyone, please, Caitlin White, please mute your line. Everyone mute your lines. And really my pleasure to introduce her. We've known each other over 20 years and have worked together. So, geez, but we're getting younger, Lona. That's the good news. At this point, I want to turn things over, and Lona, the stage is yours.
Great. Keith, I just gave an interview to New York Times about working into mid-80s with our elections coming up. So that will take us into an aging population, and we are still young and yet getting younger is what I would say. But thank you for the introduction. It's great to be here. I hope you can see my slides all right and hear me okay in this new world that we are in. Today, I would like to sort of demonstrate to you some of my early work that led to the current career path that I have, and take any questions towards the end. The outline is going to be fairly simple. I'm going to build in some of my efforts to build our research team, a collaborative team, develop a translational model on the go back when I started in infection prevention, these evolution of my own research questions with time and overall reflections on a sort of a translational research career. So I see myself as a geriatrician, an internist. I practice and see patients in nursing homes, in the VA. So I have a VA affiliation, VA CLC, as well as I attend as an internal medicine attending on the general wards, which is slowly getting rarer for specialists. But I believe I'm a patient-oriented clinical researcher. And when I started thinking about infection prevention challenges, infection prevention work in nursing homes, I felt that there are limitations to only being a patient-oriented researcher. It was extremely critical for me to think about collaborating with basic epidemiologic researchers as well as policy and practice in order for this work to move forward. And thereby, slowly, I sort of reached out to great collaborators, including Keith and John, who have a more of a patient-oriented approach, and several sort of lab-based researchers, such as Evan Snitkin, Harry Mobley for UTI work, and their mentees, as well as from the policy and practice side to Dr. Min, who's a geriatrician interested in policy and health outcomes, as well as Sanjay Saint and Sarah Krein. So the point of this research was that often we try to stay in silos, but for infection prevention research in nursing homes, a lot of people with a lot of expertise have been required. I indeed have roots in New Jersey, as Keith mentioned. I was a resident back then, came to University of Michigan and started doing some fellowship projects, moved on to junior faculty here, and then junior senior faculty and mid-career. And this is sort of the way that I approached choosing my methodologies as time went. So initially sort of thinking about quasi-experimental or joining RCTs with my mentors and thereby getting a few early publications going, understanding what research is about, and then moving on to junior faculty stage where I had my K-23 funded, an NIH Career Development Award, and other smaller grants, and then moving on to the big ones such as R01 and core, leading some cores to now where I focus again on translational studies, implementation projects, and larger cohort studies. So this is the way that I got inspired about infection prevention in nursing homes is, as many of you know, there are about 5,000 some hospitals in the United States, but there are close to 15,200 nursing homes. And yet, when I started my work back in 2003, and I went to all the geriatrics and ID meetings both, there was very little research at that time. So on any given day, 1.5 million people reside.
I don't understand what's going on here.
They have 2 million infections in a year, 40%, and I think that's a low number, harbor a resistant organism, about 300,000 transfers back to the hospital. So I sort of saw and recognized the immense potential of conducting infection prevention research in our aging populations. And that's where I started with guidance from my mentors in both geriatrics and infectious diseases. For some, it may recognize the bag on the left. When I ask folks, which I cannot ask in real time right now, but people would say this is a bag of urine. It looks like that, but this is a bag that we carry to nursing homes to dip our healthcare provider hands in there. One of my first products that I'm really proud of, and took this broth back to our lab and cultured, processed it to see what healthcare providers in nursing homes were growing. In this, being a geriatrician, I had a partner in infectious diseases, Shelley McNeil, who we both worked together, went to the nursing homes at 5 o'clock in the morning to capture the night shift. But the bottom line was we showed that carriage of gram-negative organisms, Staph aureus, and yeast was common in nursing home healthcare providers. And when we compared the use of alcohol-based hand rub versus soap, a hand rub was far more superior in removing these organisms than the soap was. This is back in, again, 2002, 2001, when the alcohol-based hand rubs were coming back. But this sort of allowed me to take a quasi-experimental study, allowed me to take a project from the beginning to the end, using primary data collection and thereby learning about what research, publication, and such activities were, leading to my subsequent work. As I thought further about where the field needs to go, I realized that as an assistant professor, early career person, the amount of work was just too large, just a lot of research.
Lona, this is Keith. I'm sorry to interrupt you. You're in presenter mode. I don't know, so we can see like your next slide and your notes. So I don't know if you can change it to just the mode where, and maybe, yeah. There you go. That's beautiful. Sorry to interrupt you, Lona.
Yeah, I figured that's okay. Great. Thank you for letting me know. Let me see, orient myself a little bit better. All right. So this was an early career project. Again, the K-23, where I felt that trying to capture and understand all different aspects of infection prevention and addressing them would have been very difficult. And I started with the highest risk population. To us at that time, the highest risk population were those with indwelling devices. So if you were to guess the number of individuals having urinary catheter in nursing home, at that time it was about 8 to 10%, and feeding tubes were about 5 to 8%. So that was a robust population that we wanted to study their overall colonization risk, their contamination risk, as well as infection risk. So this we developed two cohorts at that time, what we call devices 1 and devices 2. Devices 1 being a cross-sectional cohort and devices 2 being a prospective matched cohort, each with a control group. And we showed at that time that there was an incremental effect of Mdro colonization in those with no devices, 29 Mdros per 1,000 resident days, to feeding tubes, 63, urinary catheters, 68, and 91 if they had two catheters or two devices, then they had the highest risk of Mdro colonization. Similarly, we were able to show that infection rate was the lowest in those with no indwelling devices and the highest in those with feeding tubes and urinary catheters. It seems very intuitive right now, but when at the stage that we were at that time, this was one of the very early papers that showed these kinds, that quantified this kinds of risk that older adults were having as a result of using urinary catheters and nursing home and feeding tubes. That all led to us trying to understand the basic baseline competences of our healthcare providers as they take care of our older adults with indwelling devices. So we published papers on infection prevention programs, which showed that this 15,000 nursing homes, there was an immense variability in adoption of infection prevention program. Each nursing home was very unique to the other. There were significant gaps among healthcare professionals and knowledge about these indwelling devices, how to insert them, how to maintain them, how to reduce risk of infection, what kinds of preventive policies that should be taken at the time, at the point of care. The frontline staff getting their opinion was important to us. They expressed significant concerns regarding isolation policies and practices in older adults. So in all of this thinking, being a geriatrician, doing ID work, these two mentors were instrumental in refining my thinking about taking it to the policy level and thinking through about the intervention that I had all plans to develop next. All of these papers were well received, well published, and well recognized to then start informing policies. As I wrote my first what we call independent grant, the R1 grant, I got a chance to look at various different randomized controlled trials and study designs. There are RCTs where we randomize patients, but clearly my work was not randomizing patients, but randomizing organizations, what we call nursing homes. That required a cluster randomized study design where we would randomize a nursing home and not necessarily a patient, because the policies within a nursing home could be very similar, impacting would be very similar within the nursing home than among the nursing homes. So we approached 13 nursing homes for now developing an intervention which would allow us to develop 4 or 5 evidence-based points or a bundle of evidence-based practices that the nursing homes and their staff consistently applied. We approached 30 nursing homes in Southeast Michigan. 6 were randomized to intervention, 6 to control. As cluster randomized trials go, this was probably on the smaller side of a cluster randomized trial. However, they were very well matched in terms of the number of residents eligible, those who had indwelling devices, and were not on end-of-life care. The number that enrolled, because we took informed consent from each and every resident, and the number of visits that we had, the study visits that we had. This is my beautiful state of Michigan. We live in Ann Arbor, and you can see where our control and intervention nursing homes were. The farthest nursing home was about an hour away from our university. But we did go out to understand how other nursing homes are applying infection prevention practices, and also to make sure that our study, although in the state of Michigan, was more generalizable than staying within our city of Ann Arbor. Our intervention was, as I mentioned, fairly simple. We wanted to have our healthcare providers wear preemptive gowns and gloves. And the reason and the term preemptive was very important to us. We wanted our nursing homes were not going to be able to do surveillance cultures to see who is colonized and who is not. based on our prior data, we knew that if you have an indwelling device, you are either already colonized or infected with a drug-resistant organism. And that was the reason to use preventive gowns and gloves. That a healthcare provider going in to care for an older adult with a urinary catheter should expect splashing, should expect some sort of transmission, and thereby just be prepared. We more importantly gave the data back on a monthly basis. So it was a data for action type of approach, active with feedback reports to the leadership and also to the unit managers to then help disseminate the information that we were finding, as well as suggest 1 or 2 key points of improvement. All of this was with support of our staff doing hand hygiene promotion in services, giving them pocket cards, and train the trainer approach. On the control side, the bare precautions were allowed to use as standard precautions. The feedback was passive with no, there was no feedback. We collected outcomes, cultures, and data, and education was as needed. For example, there was a state survey and they were cited for a particular practice. We would go in and educate them on that. This is just one of the most successful, very simple tool that we used. Again, this was all back in 2008 and 9 on pandemic, before our pandemic hit. Clearly, we showed them what a good technique for hand hygiene was and not so good technique for hand hygiene. This kind of visuals were very well received and made to us a huge impact in our healthcare providers' understanding of simple things such as hand hygiene. We created several song routines and dance routines and such. This was one of our hand hygiene song and dance routine on Hit the Road Jack, a song that many of you might be familiar with. Our main results. So we clearly for 3 years did not know which of our interventions were working or not. We did not have, since it was an RCT, we did not look at the data until the very end. But we're pleased to show that about 25% reduction in all multi-drug resistant organisms, largely driven at that time with new MRSA acquisition, which was reduced again close to 25%. But more importantly, and to our surprise, we showed with these practices a reduction in any new catheter associated UTI and time to first new catheter associated UTI. And to us, this was a smaller study, one of the first cluster randomized studies done in nursing homes. And we felt that the simplicity of practices that we had and the approach of implementation that we had made a difference. We did an economic evaluation of this particular program for 1 year, one facility, about 100, average of 120 beds. We showed that it cost about $20K per year of program costs that would be borne by the facility, about $54K per year in county treatment cost, and thus about $34K per year in net cost savings. However, although the costs are borne by facility or the nursing home, most of the savings would go to the funders, CMS, or the funders that fund our nursing homes. And to my surprise, when we started talking about these results, our basic science crew, our colleagues from microbiology and immunology were extremely interested in getting a hold of our data, our microbes, and our clinical data, and went on to publish several key early studies to then use that as a base for future grants, including mentees that are Erica Flannery, Chelsea Armbruster, as well as Joyce Wang and Evan Smith. And all of these papers, again, served as pilot data for them to submit their own independent R01. We also took this 12 nursing home study to a larger national implementation project to reduce catheter-associated UTIs in nursing homes. So the focus was on only UTIs, not drug-resistant organisms. We recruited close to 435 nursing homes across the nation, all 50 states. 71% of the sample stayed in the study for this implementation project. We had monthly coaching calls, collected data, coached our sites to to implement some of the strategies we used in our patient-oriented studies, and showed that the UTI rates catheter-associated UTI rates can go down, and with 75% of our nursing homes showing at least a 40% reduction. So we felt that we made important progress with both in this field, with both patient-oriented studies as well as implementation-based collaboratives. So the lessons that we learned were that it is possible to conduct RCTs in nursing homes. There were many people who cautioned us, our team, against doing RCTs because it is indeed a very difficult setting, as all of you know, and the pandemic has taught us. But we felt that it was possible. There has to be a starting point. RCTs as junior faculty is risky and slow. It took us 4 years to publish the first paper, but it was incredibly rewarding. Several pilots for our mentees leading their own papers and grants and faculty appointments. And then it is risky. It is hard work to implement these smaller RCTs into larger projects, but it is crucial to do that. As we were doing these projects, we also sort of learned with boots on ground that the population was changing significantly between when we did the studies from 2003 to 2008 and 2009, bulk of our work. We noticed that the prevalence of urinary catheters was going down from 8 to 10% to less than 5%. So if we look at, say, prevalence of urinary catheters, go to your ICU, about 60% of your ICU patients would have an indwelling urinary catheter. If you were to go today and survey your regular medical wards, about 20% would have them. In nursing homes, it started going down such that the number of catheters used would be 5% or less. And the reason was, the singular reason was the star rating of nursing homes, which came about during that time. One of the quality indicators for that star rating was urinary catheters. So a urinary catheter placed and kept so that it excluded ISCs would be poor quality of care. And that really got the nursing homes working harder and harder towards removal of the catheters. That was number one change that we saw. The second change that we saw was because of the changing CMS and Medicare policies, we were seeing a short stay population. So the ones that we recruited thus far majority were long stay that we could follow often for 6 months, 9 months, a year. But now we were seeing short stay where patients would come in for 3 weeks, 4 weeks, funded by Medicare, and then the explicit intent was for them to go home. Thus, we realized that we had to sort of have an evolution of our research questions and the science. Clearly, there were no major studies done from infection prevention perspective on the short stay population. We saw a huge opportunity there to write more grants and conduct more projects. So the next few slides are going to go over some of the work that we did and continue to do on this short stay population. This was one of the first papers that came out of the next grant, which was solely focused on short stay, 6 local nursing homes, an in-depth large cohort of short stay population, 651 patients, about 1,629 study visits, and close to 7,500 samples were collected during the study period. I was here joined by Dr. Lillian Min, and a geriatrician and outcomes researcher, and my lab partner, Marco Cassoni, who is a research investigator in our lab. And what we showed was that close to 50% of our older adults come into a nursing home with a drug-resistant organism, and a nearly similar number are discharged into the community with a drug-resistant organism. This was a surprise to us, particularly the discharge piece, because these are short-stay individuals not going to be in the nursing homes for long. That was a paper that, again, sort of received a lot of traction, and with these samples set us up for many subsequent site projects. One of the questions that came up and observations that were made by our field staff was that while there were 15,000 papers published on healthcare provider hand hygiene, we had absolutely no idea what was on patient hands. So this was a mid-cohort small letter that we published along with one of my mentees, Ji Chow and Betsy Foxman from School of Public Health. And we showed that about 25% of older adults coming to these nursing homes had a drug-resistant organism on their hands. This was, and then there were several who acquired a new MDRO while in the nursing home. Most commonly found were MRSA, resistant gram-negative organisms, and the VRE. So during the entire follow-up period, about 34% were colonized with at least one drug-resistant organism. That led us to one more study here reflecting on our acute care population. Some of the co-authors included Dr. Keith Kay, who's here, extended our already close collaboration from before. Here we recruited 2 hospitals, University of Michigan Hospital. So here we went upstream, thinking about if we are seeing this in nursing homes, what's happening in the hospitals? So 2 hospitals, we recruited 399 patients within 24 hours of their admission to the floor, to a medical floor, 710 patient hand cultures, and close to 4,000, over 4,000 room cultures. And we showed that 10% of our patients in the hospital had an MDRO on their hands on admission, 6.2% new acquisition, and about 13% anytime during their stay. In the environment, 40% of environment was contaminated with a drug-resistant organism. And there was a correlation, MDRO on patient hands correlated with MDROs in the environment, although this study did not prove the directionality of the transmission between hands and environment. But we showed that if hands were positive, then there was more likelihood of environment to be positive. Hands were negative, there were more chances of environment to be negative. And again, this finding intrigued us even further into looking at the role of patient hands in environmental contamination in hospitals and, more importantly, in nursing homes. This is a paper that Marco Cassoni, my lab partner, wrote where he said that, and he had seen us going in the field, trying to recruit our older adults, get consents from them was extremely difficult. And we would lose, our consent rate at best would be 45% agreeing to be part of these studies. So we would lose the other 55% who were not. And what he proposed was that in those people, if we did just environmental sampling, would that serve as a proxy for patient colonization? And he showed elegantly in this paper where both for MRSA and for VRE, the negative predictive values were pretty high, about 92 and 82%, which would suggest that if the environment was negative, there was less chance. There was very good correlation that the patient was negative as well. And the environmental surfaces that he studied were TV remote control, bed rail, nurse call button, bed controls, which were very likely to be contaminated. This again led to one of our students thinking about doing a pilot study to understand contamination of nursing home common area and rehab gym environment with drug-resistant organisms. One of the main reasons that our geriatricians, our patients go to nursing homes are for rehabilitation. They need to get stronger before and more ADL, activities of daily living, independent to be able to take care of themselves at home. So their visits, and I'll show a little bit more later on as well in a couple of slides. We wanted to follow a few people into the rehab environment and show the transmission of organisms. This was published, I want to say 2015, where Kyle followed about 10 patients into their various activities and showed that 13% of common area surfaces were contaminated with drug-resistant organisms. These included shower room, rehab gym, and hallway handrails touched by our patients and our healthcare providers. About 8% of rehab gym equipment surfaces were contaminated with drug-resistant organisms. Most contaminated were an arm bike, a pulley, and stairs, the gym stairs. And the pathogen transfer happened in about 17%, where half of all, that was all, about half of all surveilled rehab sessions where the transmission from hand to equipment happened about in 2 situations and about 4 situations out of 10 from rehab gym equipment to hand. Similar to those projects, we showed that transmission of resistant gram-negative organisms were common in, and this was a study done by Mary Claire Rockman, one of our other colleagues at Maryland, during care of residents in community-based nursing homes. They studied 403 interactions, a number of interactions, 403 patients with about over 500, almost 600 interactions between the healthcare provider and the patient. Number of patients colonized with resistant gram-negatives was about 19%. RGNB transmission on gowns and gloves about 11%. The highest risk activities included showering, hygiene or toileting assistance, and wound dressing changes. A similar study from acute care, a meta-analysis of this particular question showed that if you had ungloved hands, the transfer of pathogens was about 33%. If you had gloved hands, about 30%, gowns 10%, and hands after removal of gloves about 3%. Transmission from patient and their environment onto healthcare worker hands. There were several factors that would influence this transmission, including moisture, so was it a wet activity or not, longer duration of care, and use of invasive devices. Some of this, especially our hand hygiene studies, found its way into lay public, and these were the years where just pre-pandemic, where we started getting calls already from the press about patient hand contamination and environmental contamination, and we were glad to see this interest from our lay public to then inform our future studies as well. And one of the pilot studies that we did was with John over here and my research investigator, my research coordinator, Kristen Gibson, was how often do we see these drug-resistant organisms on privacy curtains in nursing homes? Curtains are used in nursing homes, but also in hospitals. We use curtains all the time. It was a very simple study, just culturing, and we had already stored many cultures from our previous studies. If we just analyzed the curtains alone, about 1,521 samples, 22% were contaminated with drug-resistant organisms, 14% with VRE, 6% with RGNB, and 5% with MRSA. Again, this simple study just got a lot of traction in the press. And this study, even without a publication, it was just presented at one of the European meetings, and it got a lot of attention at that time. Again, we felt that this sort of was a study which helped us understand transmission. I would say that the main critique and a question to further ask is, were the strains that were found on this curtain similar to what was found on the patient, or it was somebody else touching the curtain and thereby contaminating it? We got called by many companies who wanted to who presented alternatives to using these sort of barriers for privacy when we do physical exams or the kind of procedures for our patients. All of this to say that used as incredible amount of data to then develop a study to thoughtfully look at transmission in a larger format. Several of you might be working at the VA or might have familiarity with the VA setup, so to speak, where the nursing homes, or what we call the community living centers at the VA, are often attached to the hospital, the VA hospital. What that does is that the folks in the CLC, if they want to go out for rehabilitation, for occupational therapy, they use the same facilities, the same equipment as a hospitalized patient would use. We felt that we were ready to now take a look at transmission that might happen at out of the room visits for medical appointments and recreation across the VA CLCs, and to develop a pilot educational intervention involving veterans, their families, healthcare personnel, as well as leadership to reduce transmission of infections. So in the next few slides, what I'll show you, next 3 to 4 slides are very, very early data on this particular project. Our goal, we are in the year 2 of our study, the observational phase, and we'll be starting to think about our intervention in the next few months. So this is where we are right now. In our study, we are recruiting patients from 3 different facilities, VA facilities, CLCs, where we enroll patients, CLC patients, usually for short stay, but could be for long stay, where we would call them residents, and including sort of unique situations, such as if they have spinal cord injury, which we have very few. So very few exclusions, basically, trying to understand the entire population and different kinds of populations at Ann Arbor, Cleveland VA, and Detroit VA. We have recruited about 150 people, 41% have agreed to our studies. Again, if we are happy, if 40 to 50% of our eligible folks agree to our projects, we are happy with that number. We wish it was higher, but that is just the nature of this population and recruitment. We recruit them, we culture them from their nares from the nares, groin, and hands, and we culture during the in-room visits, their in-room surfaces. And after that comes a more innovative part, where if they're going for physical therapy or dialysis or radiology or radiation oncology, we follow them. My research staff follows them through those studies, and we culture both the surfaces and the hands during those study visits. In terms of our, this study was funded pre-pandemic, but we started recruitment during pandemic. And there are a couple of sort of challenges that we have faced. Number one is that the out-of-room visits have gone down substantially as a result of pandemic. A lot of physical therapy, a lot of occupational therapy is provided in the rooms. Now that is changing, but at least early on in our recruitment stage, a lot of visits were happening in the room versus the prior norm of going outside the room. Again, our inclusion criteria are newly admitted patients to the VACLC to recruit them within 3 days of admission, get informed consent from the patient or their legal representative. Exclusion if they were not screened within 3 days, if we were unable to contact their legal guardian, if they were receiving end-of-life care. In this slide, and just focus, a lot of numbers, but focus on the last column, about 81% of our patients have a drug-resistant organism either on the patient's site or on the environmental site. 81%. 62% colonized with a drug-resistant organism, and 75% of the environmental sites contaminated with a drug-resistant organism, being MRSA, VRE, or resistant gram-negatives. And we do change our denominator based on the number of visits and swab levels. So we have conducted 500 some visits and have recovered a drug-resistant organism in 38% of visits from a patient site and 46% of visits from the environmental site. Similar data on our swab level analysis. The most common contaminated site, groin, 31%, and hand, about 19% here. You'll notice that we have done away with rectal cultures to make the studies easier for our patients, our subjects. In terms of the in-room contamination, toilet seat, curtain, and bed rail are the most contaminated sites, about ranging from 21% to 17%. 300 data from about 300 some appointments out of room visits. Most common places that our patients, CLC patients go to in this VA CLC setting are physical therapy and occupational therapy. 57% of our visits that our study staff followed were in these two places. And this is how we describe our transmission events. And this definition we have refined over time as we wrote our grants and discussed this with many individuals. A destination surface is a surface or object or hand for which both a before and after swab is collected, right? So that is our destination surface. Microorganism transfer is identification of microorganism on destination surface that were not contaminated before the source interaction. So again, these definitions were developed after a lot of thought to start understanding what we mean by transmission, the role of patient hands during this out-of-room visits in overall transmission. This is an example of a visit and how we collect data to understand this. So before rehab visit, this is a patient my coordinator would follow. Before the rehab visit, she would culture the veteran hand. During the rehab visit, she would again sort of first culture the weight that the patient used, and then culture patient hand after the use of the weight, culture the walker before use and after use, culture the blood pressure machine before and after use, a healthcare provider who was measuring the blood pressure, and after rehab visit would also culture patient hand, and an occupational therapist hand who worked with the patient. And here you can see that the patient was positive for VRE before he started the rehab visit, remained positive during the rehab visit. The equipment, the weight turned positive after the patient touched it. However, the walker remained negative, the blood pressure cuff remained negative, the physical therapist who did the blood pressure measurement remained negative, but it was picked up by an occupational therapist who worked with the patient who helped the patient with several therapy maneuvers. This is again a slide which shows overall just an MDRO, not really the transmission, but overall contamination that we see during these visits. The dialysis visits are where we see the most surface contamination and the patient contamination. Those who require dialysis are, as all of you know, just a special sort of high-risk group of individuals, followed by X-rays, followed by therapy and other appointment, radiation being one of these safer appointments. All of this to say that transmission and a person coming in contact with contaminated surfaces is high when our patients go out for these kinds of visits. So next steps in our project is certainly to develop interventions, and we are going through this data to inform our pre and post study that will be starting in the next few months. As I close and I reflect upon all of these projects and the research and the career development that I have been lucky to provide, I feel that having a vision very early on about what is needed in this field, and having a population-based vision, which is what I felt thinking about a nursing home population that was really not studied well, was very important for the work to move forward. It was this particular mission that my research staff has bought into and have stayed with me for a long time, which has held us together. Early hires to me in building up this research team were critical. They served as my building block for all the work, all the processes that we set up. It is important to lead by example and with optimism, particularly in research where funding can turn dry, and it is very cyclical in nature. When I work with my research staff and my mentees, we always insist on integrity early and often. With this data, we have a lot of information on our hand and a lot of freedom to use this information the way that we want to use. Promoting curiosity in our junior investigators, especially now that we have so few junior people pursuing the physician scientist route. I take it to promote curiosity by the way of these kinds of projects. It's important for us as investigators to recognize talent and passion, and always nurture that. Discourage stagnancy, never be stagnant in your work, always take risk, calculated risk, communicate, over communicate. As a woman faculty researcher in life, I have learned when to lean in and work really hard, and when to lean out and sort of let go of certain things that are not as interesting, or maybe just lean out because of whatever circumstance that has come our way. And to always celebrate success and hard work. As I think about my research career, I am reminded about this quote from Vincent van Gogh, one of my favorite artists, who says that a weaver who has to direct and to intervene a great many little threads has no time to philosophize about it, but rather he's so absorbed in his work that he doesn't think about acts, and he feels how things must go more than what he can explain it at that time. So I'm going to stop there, acknowledge my incredible team members who simply make my work really, really easy. Thank you.
Lona, that was wonderful. Thank you for really kind of a career retrospective, and also incredible education and update on resistance period, but also particularly in the nursing home. I just wanted to ask you, just to kick off questions. You showed a slide about your nursing home network that seems mostly focused in southeastern Michigan. While some on the call may not recognize, this is quite an accomplishment. It's not easy to establish academic networks such as this. And this is beyond academic. I know it's quality improvement that you brought infection control and stewardship principles forward and helped them. But any tips or insights into the do's and do nots in terms of trying to establish these types of networks?
Yeah, I think there are several sort of simple things that we can do but number one is to establish a relationship. I think that is the key. So when we go to a nursing home, the PI, as a PI, I would go there with any of the initial 2 or 3 visits that are required to onboard a nursing home. It is not enough to send my staff over there. So I feel that it is important for the entire team to go, but definitely for the PI to go there. And the first thing we do is we just tour the facility. The idea is to understand their passion. Each nursing home has their own philosophy, their own mission and vision, so to speak, that drives them. So it is important to sort of tour the facility, learn about their patients, learn about the residents and the type of care that they provide. And then we sort of sit down and talk about the research projects. It is true, and I talk about it all the time with them, that what they do and the contributions that they have made by being part of their study has set the national stage for other groups to develop consortia, for other groups to do infection prevention studies in the right manner. And so I truly believe, and I convey to them that they are part of this mission, and their work and their engagement has truly changed the policy and how we care for older adults. So sort of relationship building is extremely important. Second is, the truth is, it is indeed a very hard setting, and we have to recognize that staff changes happen very commonly, impacting everything that we teach in terms of infection prevention, or for that matter, any other quality improvement projects. There is no easy way to work around, but to be there often and to encourage staff by simple things such as giving out small gifts or small knickknacks to help them take the message forward. And the third is to sort of acknowledge and recognize and appreciate and reward research staff, because they are the ones who are going out there and doing the groundwork. I have had many HR fights where sometimes they would not approve the salary that I want to pay my research staff because it is, sort of outside of the range that they set. And I think going to bat with them, for them, is important. And along those lines, mentoring our research staff, allowing them to publish be part of the authorship, just simple things like that. Sometimes we overlook it, but allowing them to be part of the authorship, listening to their suggestions on the ground, empowering them, bringing them to the meetings with me, have been some of the other softer strategies that have been important. So these are a lot of things I think that I mentioned, but if there's anything more specific, I can elaborate on.
Thanks, Lona. Any questions from folks online? Don't be shy.
And Lona, I have one question. So I guess, first of all, I always appreciate your lab groups, how multidisciplinary they were and how the data you generated, when you have a group of a dozen, smart, ambitious people together, how looking at data can generate side projects, and it's sort of, a virtuous cycle there. But you showed the early slide of sort of your career and the types of studies you did at each point. And I just wondered if you could comment on, you mentioned sort of early on doing more observational studies and then sort of the risk involved in doing more interventional stuff, and sort of how you made that leap to doing these more research intensive, long, interventional trials that span over several years, where I feel like a lot of things could go wrong, but how you were successful doing those things.
Yeah, looking back, it feels successful. When I was going through it, I had no idea what we were going to get, right? So for the early career, I would strongly advise junior faculty to be part of an already functioning group. And you want to sort of eventually be a leader of your project, but before that, it is important to join a high functioning group within your own institution, or if needed outside, but a high functioning group. So you want to sort of have a mentor with a track record. That's the one, but equally important is to have an interest in the topic, right? So those two put together will had allowed me to certainly complete my projects. The nursing home study that I did early on, we sometimes would end up in the nursing home at Glacier Hills, me and Shelley at 5 o'clock in the morning, 5:30, and get the samples. And it was because we knew that there was nothing going on, and what we in nursing homes and what we did was going to be important in forming and taking what we then knew about the role of alcohol-based hand rubs, to then allow that data to come from nursing homes per se. So sort of, and then third is really, I cannot underestimate the power of luck. I mean, for me to be a geriatrician coming to University of Michigan and having people like Carol Kaufman and Sue Bradley, who already had their heart in aging and infectious diseases, was important. The reason that I feel that I got a little bit of early success in funding, and maybe Keith can chime in as well, is that the NIH, we did, the reason I know Keith very well is we did a lot of activities, career development activities at AGS, for example, American Geriatrics Society. And those activities sort of had a career development piece to it. So it was not only ID or geriatrics, it was about grant writing high impact papers. But the point was that we organized that and got to work with many high-profile investigators across the nation as a result of it. And these meetings would be attended by NIH staff, and they got to know us and what our passion was and what drove us in this field of infection and aging, which helped with the funding. So not only is it important to have a good functioning group, not only is it important to have passion, but then to move forward, you need money. And I think getting those early grants were important for me to say that, okay, there is an external review body that is looking at our work and believing in it. And now I can propose this, which is where the field needs to go. Although it is a risk, whatever I learn is okay, because that's what I heard other people say at the meetings. They were like, okay, it's okay to fail, but it is, try it out. And so those kind of risk taking, I think I learned from all the symposiums and workshops that I organized early on, that some of them with Keith that we organized early on at national professional societies. Ultimately, it is a risk and things could go wrong. And but the data that we collected, we could have any pilot projects that move forward.
Any other comments or questions for Dr. Mody? All right, Lona, thank you so much for your time. We appreciate it and for sharing your wisdom. Everyone, you get 4 minutes back for your day and we'll talk to you all later. Thanks again, Lona.
All right, take care.
Bye-bye.
Bye.